Eye development follows a precise timeline. At day 22, the optic vesicles emerge from the developing forebrain. This early connection explains why severe eye anomalies often accompany brain malformations. Between weeks 4 and 5, the lens pellicode invaginates to form the lens vesicle. This process requires perfect coordination between surface ectoderm and the underlying optic vesicle. Any disruption here leads to absence or malformation of the lens. Weeks 6 to 7 mark critical developments. The optic cup forms through invagination of the optic vesicle, creating the structure that becomes the retina. Simultaneously, hyaloid vessels penetrate to nourish the developing lens and vitreous. These vessels should completely regress by birth. When they don't, we see persistent fetal vasculature. Week 8 brings corneal development with its 5 distinct layers forming in sequence. The precision required here explains why minor disruptions cause significant visual impairment. By week 10, the eyelids fuse, protecting the developing eye until week 26, when they reopen. Premature infants born before this reopening have fused eyelids, a normal finding that families need reassurance about. The critical period spans weeks 3 through 8. Major malformations trace back to disruptions during these 5 weeks. When evaluating congenital eye anomalies, knowing this timeline helps predict which other systems might be affected and guides your diagnostic workup. Timing determines everything in eye embryology. Early disruptions between weeks 3 and 4 cause the most devastating anomalies: anophthalmia, where the eye fails to form, or cyclopia from holoprosencephaly. These infants typically have severe brain malformations incompatible with life. Mid-disruption between weeks 5 and 7 produces microphthalmia and colobomas. Colobomas appear as keyhole-shaped defects, typically inferior, where the optic fissure failed to close. When you see a coloboma, immediately think charge syndrome. Colobomas are the C in charge. These babies need comprehensive evaluation, including cardiac echo and genetic testing. Later disruptions after week 8 affect more superficial structures. Congenital cataracts and anterior segment dysgenesis occur when lens development goes awry. Unlike early disruptions, these often occur in isolation with better prognosis if treated promptly. Persistent fetal vasculature deserves special attention. The hyaloid vessels should involute completely, but incomplete regression leaves remnants. You'll see a white pupil, leukocoria, which requires immediate ophthalmology consultation to differentiate from retinoblastoma. Understanding embryologic timing transforms your clinical approach. A baby with bilateral anophthalmia needs brain imaging and genetic consultation immediately. An infant with isolated cataract needs prompt surgical evaluation, but likely has normal development otherwise. This timeline-based thinking helps you anticipate problems, counsel families accurately, and recognize patterns in clinical practice. The neonatal eye examination requires systematic evaluation. Start with the red reflex. This single assessment catches most serious pathology. A normal red reflex appears orange-red and symmetric. An absent or white reflex demands urgent ophthalmology referral. Leukocoria suggests cataracts, retinoblastoma, or persistent fetal vasculature. External inspection reveals crucial information. Note eye size, spacing, and symmetry. Hypertelorism, increased spacing between eyes, often accompanies chromosomal abnormalities. Hypotelorism suggests midline defects, including holoprosencephaly. Asymmetric eye size indicates possible glaucoma or microphthalmia. Corneal diameter measurement distinguishes normal variation from pathology. Normal ranges from 9.5 to 10.5 millimeters. Enlarged corneas greater than 12 millimeters suggest congenital glaucoma. These babies present with tearing, photophobia, and the classic ox-eye appearance. Small corneas under 9 millimeters indicate microphthalmia requiring genetic evaluation. Pupillary responses confirm intact neural pathways. Both pupils should constrict equally to light. Asymmetric responses suggest nerve damage from birth trauma or underlying neurologic abnormality. Fixed, dilated pupils in an otherwise well infant may indicate pharmacologic mydriasis from maternal medications. 3 findings mandate urgent consultation: cloudy cornea, absent red reflex, and purulent discharge. A cloudy cornea in the first 24 hours typically means congenital glaucoma requiring immediate pressure reduction. Purulent discharge, especially within the first week, raises concern for gonococcal conjunctivitis, a true ophthalmic emergency requiring systemic treatment. Eye prophylaxis prevents ophthalmia neonatorum, particularly gonococcal conjunctivitis, that can cause blindness within days. 3 agents provide effective prophylaxis: erythromycin 0.5% ointment, tetracycline 1% ointment, and povidone iodine 2.5% solution. Erythromycin remains the standard in most nurseries. Apply a thin ribbon along the lower conjunctival sac within 1 hour of birth. The antibiotic provides coverage against gonorrhea and some chlamydial strains. Parents often worry about the temporary blurred vision. Reassure them this resolves within hours. Tetracycline offers similar efficacy, but has become less available. Povidone iodine deserves consideration, especially in resource-limited settings. Studies show equal or superior efficacy compared to antibiotics. It's less expensive and doesn't contribute to antibiotic resistance. The brownish discoloration alarming to parents washes away quickly. Timing matters. Prophylaxis works best within the first hour after birth. Delayed application reduces effectiveness. Some units delay prophylaxis briefly to facilitate parent-infant bonding, but never beyond 1 hour. Despite prophylaxis, no agent completely prevents infection. Chlamydia, the most common cause of neonatal conjunctivitis, often breaks through antibiotic prophylaxis. Any infant developing conjunctivitis needs evaluation regardless of prophylaxis status. Chemical conjunctivitis from the prophylactic agent itself appears within 24 hours and resolves spontaneously. True infection typically presents after day 3 with increasing severity. This temporal pattern helps differentiate benign from serious causes. Timing guides your approach to neonatal conjunctivitis. Chemical conjunctivitis appears within 24 to 48 hours after prophylaxis. The infant develops mild lid swelling and watery discharge that resolves without treatment. Parents need reassurance, not antibiotics. Gonococcal conjunctivitis represents a true emergency. Presenting between days 2 and 7, it produces copious purulent discharge and dramatic lid swelling. The organism can perforate the cornea within hours, causing permanent blindness. Any purulent discharge in the first week demands immediate gram stain, culture, and empiric treatment with intravenous ceftriaxone. Don't wait for culture results. Treat immediately while monitoring for corneal involvement. Chlamydial conjunctivitis typically appears between days 5 and 14, making it the most common infectious cause. The discharge starts watery, then becomes mucopurulent. Unlike gonococcal infection, progression is slower but still requires systemic treatment. Oral erythromycin treats both the eye infection and prevents chlamydial pneumonia that can develop weeks later. Remember to treat both parents. Maternal cervical infection is the source. HSV conjunctivitis presents between days 6 and 14 with vesicular lid lesions and keratitis. The cornea shows characteristic dendritic ulcers on fluorescein staining. These infants need immediate systemic acyclovir, as 70% with eye involvement develop disseminated disease. Always obtain cultures before starting treatment: gram stain, routine culture, chlamydia, and HSV PCR. But when faced with purulent discharge, begin empiric coverage immediately. The consequences of delayed treatment far outweigh the risks of unnecessary antibiotics in this setting. Primary congenital glaucoma results from elevated intraocular pressure, causing progressive optic nerve damage. The fundamental defect lies in trabecular meshwork dysgenesis. Abnormal development of the drainage system prevents aqueous humor outflow, leading to pressure buildup. This condition affects 1 in 10,000 to 20,000 births, with males comprising 65% of cases. 3/4 present bilaterally, though one eye often shows more severe involvement initially. The asymmetry can mislead clinicians early in the disease course. Presentation varies significantly. Some infants show signs at birth. Cloudy, enlarged corneas immediately alert the delivery team. Others develop symptoms gradually over the first year as intraocular pressure rises. This variable onset reflects the spectrum of trabecular meshwork abnormalities. The developmental defect involves incomplete differentiation of the trabecular meshwork and Schlemm's canal. Unlike adult glaucoma, where the drainage system deteriorates over time, these infants are born with structurally abnormal filtration angles. The severity of the anatomic defect determines age at presentation and response to treatment. Early recognition changes outcomes dramatically. While the incidence seems low, the bilateral nature and male predominance help identify at-risk infants. Any infant with unexplained tearing, light sensitivity, or corneal enlargement needs immediate evaluation. The window for preserving vision narrows quickly as pressure damages the developing optic nerve. The pathophysiology centers on blocked aqueous humor drainage at the trabecular meshwork. Aqueous humor, continuously produced by the ciliary body, normally flows through the pupil and drains via the trabecular meshwork into Schlemm's canal. When this pathway is blocked, pressure builds relentlessly. Elevated intraocular pressure affects infant eyes differently than adult eyes. The infant's cornea and sclera remain distensible, stretching under pressure rather than maintaining shape. Corneal stretching produces Hobbs striae, horizontal breaks in Descemet's membrane visible as railroad track-like lines across the cornea. These represent permanent structural damage, even if pressure normalizes later. Scleral stretching creates ophthalmos, literally ox eye, the pathognomonic finding of congenital glaucoma. The entire globe enlarges, giving the characteristic appearance that families often notice first. This enlargement only occurs in eyes younger than 3 years old. After that, the sclera becomes rigid like adult tissue. Meanwhile, the optic nerve suffers progressive damage. Elevated pressure causes cupping and atrophy of the nerve head. Unlike adults who lose peripheral vision first, infants develop diffuse vision loss. The developing visual system cannot compensate for this damage. Without treatment, the cascade progresses to irreversible blindness. The cornea becomes increasingly opaque from edema, the globe continues enlarging, and the optic nerve atrophies completely. Understanding this progression emphasizes why immediate surgical intervention is crucial. Medical management only temporizes while permanent damage accumulates. The classic triad, epiphora, photophobia, and blepharospasm, appears in most affected infants. Parents describe excessive tearing not associated with crying. The photophobia can be severe. Infants bury their faces in their parents' shoulders when exposed to light. Blepharospasm, involuntary lid squeezing, accompanies the light sensitivity as the infant tries to protect painful eyes. Ophthalmos remains the pathognomonic finding. The enlarged eye develops from scleral stretching under elevated pressure. Parents might comment that one eye looks bigger or more prominent. This finding alone, even without other symptoms, confirms the diagnosis. The cornea tells the story. Normal newborn corneas measure 9.5 to 10.5 millimeters. In glaucoma, corneal diameter exceeds 12 millimeters and appears hazy from edema. The enlarged cloudy cornea creates the characteristic appearance that prompts referral. Hobbs striae, those horizontal breaks in Descemet's membrane, confirm chronic pressure elevation when visible. Behavioral changes often accompany the eye findings. Infants become irritable and feed poorly, turning away from light sources. Parents report their baby seems uncomfortable in bright environments and sleeps better in darkened rooms. Some infants develop a preference for keeping their eyes closed. The presentation spectrum ranges from obvious ophthalmos at birth to subtle tearing in an otherwise well infant. Bilateral involvement doesn't mean symmetric presentation. One eye often leads, potentially delaying diagnosis of the less affected eye. Any combination of the classic triad warrants immediate evaluation. When an infant presents with excessive tearing, 3 main conditions enter the differential. The corneal appearance immediately distinguishes between them. Nasolacrimal duct obstruction causes tearing in 10% of newborns. These infants have clear, normal-sized corneas with no photophobia. The tearing worsens with crying or cold weather. Gentle pressure over the lacrimal sac produces reflux of mucopurulent material. The infant remains comfortable in bright light, feeding normally without distress. Congenital glaucoma presents with cloudy, enlarged corneas exceeding 12 millimeters. The photophobia is striking. Infants actively avoid light and show clear discomfort in bright environments. The tearing occurs constantly, not just with crying. No discharge accumulates because the problem involves pressure, not obstruction. Corneal abrasion shows acute onset following trauma, even minor trauma from fingernails or blanket fibers. The cornea remains normal-sized, but shows epithelial defects with fluorescein staining. These infants display sudden onset symptoms rather than the progressive course of glaucoma. The key discriminator remains corneal evaluation. A large, hazy cornea means glaucoma until proven otherwise. Clear corneas of normal size point toward nasolacrimal duct obstruction or other causes. This simple assessment guides urgency. Cloudy corneas need immediate ophthalmology evaluation, while clear corneas with tearing can be managed expectantly initially. When uncertainty exists, measure corneal diameter. Numbers don't lie. Anything over 12 millimeters demands urgent referral. Congenital glaucoma requires urgent ophthalmology referral. This cannot be overstated. Unlike many pediatric conditions where observation is reasonable, glaucoma causes irreversible damage with each passing hour of elevated pressure. Medical therapy serves only as a temporizing measure before surgery. Topical beta blockers like timolol reduce aqueous production but require careful monitoring for systemic effects, including bradycardia and bronchospasm. Carbonic anhydrase inhibitors, either topical dorzolamide or oral acetazolamide, provide additional pressure reduction. Prostaglandin analogs increase outflow but work poorly in infants due to their abnormal anatomy. These medications buy time, not cure. Surgery remains the definitive treatment. Goniotomy or trabeculotomy represent first-line procedures, directly opening the abnormal trabecular meshwork to establish drainage. Success rates approach 80% when performed early. The surgeon either approaches internally through the cornea for goniotomy or externally through the sclera for trabeculotomy. Refractory cases require more aggressive intervention. Trabeculectomy creates a new drainage pathway, bypassing the trabecular meshwork entirely. Tube shunts provide drainage through an implanted device when other surgeries fail. These procedures carry higher complication rates but may preserve vision when simpler operations prove insufficient. Lifelong monitoring continues regardless of surgical success. Intraocular pressure can rise years after initially successful surgery. These children need regular examinations, including pressure checks, optic nerve evaluation, and refraction monitoring. Even with optimal treatment, many develop myopia and amblyopia requiring ongoing management. Congenital cataracts represent any opacity in the crystalline lens that's present at birth, affecting about 1 to 6 per 10,000 live births. What makes this condition particularly significant is that it remains the leading cause of preventable childhood blindness worldwide. When we look at causation, the distribution follows a fairly even rule of thirds. About 1/3 are hereditary, another third associate with various syndromes, and the final third remain idiopathic despite our best investigative efforts. The timing here is absolutely critical for visual development. For unilateral cataracts, those first 6 weeks represent a crucial window where the visual cortex is rapidly developing its connections. With bilateral cataracts, we have slightly more time, up to 10 weeks, but the urgency remains paramount. The developing visual system requires clear, focused images to establish proper neural pathways. Without intervention during these critical periods, irreversible deprivation amblyopia develops, fundamentally altering the child's visual potential for life. This timeline drives every clinical decision we make in these cases. The etiology of congenital cataracts spans multiple categories, with genetic causes leading the way. Autosomal dominant inheritance patterns are most common, making family history essential during your initial evaluation. Metabolic disorders present another crucial category. Galactosemia stands out because early dietary intervention can actually prevent cataract progression, making newborn screening results vital to review. Low syndrome, with its characteristic combination of cataracts, intellectual disability, and renal tubular dysfunction, appears frequently on exams. Infectious causes follow the classic torch pattern, with rubella historically being the prototype. These infants often present with the full rubella syndrome, cataracts, cardiac defects, and sensorineural hearing loss. CMV and toxoplasmosis can produce similar lens opacities, though typically with additional systemic findings. Chromosomal abnormalities including trisomies 21, 13, and 18 frequently feature cataracts as part of their phenotype. Iatrogenic causes, particularly from systemic steroids, remind us to carefully consider medication history in any infant with lens opacities. Your clinical takeaway? Always check the red reflex during every newborn exam. This simple screening tool catches most congenital cataracts early when intervention can make the greatest difference. The hallmark finding in congenital cataracts is an absent or abnormal red reflex, presenting as leukocoria, that white pupillary reflex that immediately raises concern. Parents might notice this as a white spot in flash photographs or describe the affected eye as looking different. When cataracts are bilateral and dense, nystagmus often develops within the first few months of life as the visual system searches unsuccessfully for clear images. This pendular or searching nystagmus signals significant visual impairment and often indicates we've already missed some of the critical period for visual development. Strabismus frequently follows as binocular vision fails to develop properly. The brain essentially gives up trying to fuse two very different quality images, allowing the eyes to drift. Location matters significantly for prognosis. Nuclear cataracts, the most common type, affect the central lens and typically cause more visual impairment than peripheral opacities. Cortical cataracts involve the lens periphery and may allow some functional vision if the visual axis remains clear. Posterior subcapsular cataracts sit right in the visual axis and significantly impact vision despite their often small size. Total or mature cataracts completely opacify the lens, leaving no doubt about the need for urgent surgical intervention. Evaluating an infant with congenital cataracts requires a systematic approach beginning with comprehensive ophthalmologic examination. The ophthalmologist needs to assess not just the cataract, but the entire visual system's integrity. When dense cataracts prevent visualization of the posterior segment, B-scan ultrasonography becomes essential to rule out concurrent abnormalities, like persistent fetal vasculature or retinal detachment that would affect surgical planning and visual prognosis. The workup for underlying etiology directly impacts management and genetic counseling. Torch titers help identify infectious causes, though timing matters. IgM antibodies suggest recent infection, while IgG indicates past exposure or maternal transfer. Urine-reducing substances screen for galactosemia, where positive results mandate immediate dietary modification to prevent systemic complications beyond the cataracts. Calcium and phosphorus levels can reveal rare metabolic causes like hypoparathyroidism. Genetic testing increasingly plays a role, particularly with bilateral cataracts or positive family history. Several genes including CRYAA, CRYAB, and GJA8 link to congenital cataracts. Throughout this evaluation, assessing visual potential remains paramount. Factors like cataract density, location, associated ocular abnormalities, and timing all influence whether surgical intervention will meaningfully improve visual outcomes. Managing congenital cataracts revolves around one fundamental principle. Timing determines outcome. Dense unilateral cataracts require surgery by 6 weeks of age to prevent irreversible deprivation amblyopia in the affected eye. The fellow eye continues sending clear signals to the visual cortex, creating a competitive disadvantage that rapidly becomes permanent. Bilateral dense cataracts allow slightly more flexibility with surgery recommended by 10 to 12 weeks, since both eyes are equally affected and the brain isn't preferentially developing one visual pathway over another. Not every cataract requires immediate surgery. Partial cataracts that maintain a good red reflex and allow the infant to fixate and follow can be observed closely. Serial examinations help determine if the opacity is progressing or interfering with visual development. The decision balances surgical risks against visual potential. Surgery in a newborn carries inherent challenges, including difficult optical rehabilitation and higher complication rates. Post-operatively, the real work begins. Aggressive amblyopia therapy becomes a years-long commitment for families. Contact lenses provide optimal optical rehabilitation in infants, though some centers now place intraocular lenses even in young children. Either way, preventing amblyopia requires meticulous attention to refractive correction, occlusion therapy when indicated, and frequent follow-up to ensure proper visual development continues throughout childhood. A coloboma represents incomplete closure of the embryonic fissure during early ocular development, specifically between weeks 5 and 7 of gestation. This embryonic fissure normally runs along the inferior aspect of the developing eye, which explains why most colobomas appear in the inferior location. It's simply where the final closure occurs. The defect can affect any structure along this embryonic pathway, including the iris, ciliary body, lens, retina, and optic nerve, with vastly different clinical implications depending on posterior versus anterior involvement. When the iris is affected, we see the classic keyhole pupil appearance that's pathognomonic for iris coloboma. This inferior notch in the iris creates that distinctive keyhole or cat eye appearance that's immediately recognizable on examination. The incidence runs about 1 in 10,000 births, making it uncommon but not rare enough to ignore during newborn assessments. Understanding the embryologic basis helps predict which structures might be involved. If the closure defect occurred early, multiple structures along the fissure pathway may be affected. Later closure defects might involve only anterior structures. This temporal relationship during development directly correlates with the extent of the coloboma and ultimately determines visual prognosis. The visual impact of colobomas varies dramatically based on which structures are involved. Isolated iris colobomas, despite their striking appearance, typically preserve good vision since the central visual axis remains intact. These infants might have some photophobia or cosmetic concerns, but functionally, they do well. The story changes completely when posterior structures are involved. Retinal colobomas create a gap in the neurosensory retina that cannot transmit visual information, while optic nerve colobomas can range from mild cupping to severe hypoplasia with profound vision loss. What makes coloboma evaluation critical is its frequent association with systemic syndromes. Charge syndrome represents the most common association, that acronym where the C stands for coloboma. These children present with a constellation of findings, including cardiac defects, choanal atresia, growth retardation, genital abnormalities, and ear anomalies. Chromosomal abnormalities like trisomy 13 and 18 frequently include colobomas among their ocular manifestations. Vectoral association occasionally features colobomas, though they're not part of the classic criteria. This association pattern means every infant with a coloboma requires comprehensive syndrome evaluation. The eyes often provide the first clue to a broader developmental disorder. Even isolated appearing colobomas warrant genetic consultation and careful systemic evaluation, as subtle features of associated syndromes may become more apparent with age. These emergency recognition patterns form the foundation of neonatal ophthalmology triage. An absent red reflex demands urgent ophthalmology referral within 24 to 48 hours. This finding screens for cataracts, retinoblastoma, and other vision-threatening pathology. The timing matters because early cataracts need surgery within weeks to preserve visual potential, while retinoblastoma requires immediate staging and treatment planning. A cloudy, enlarged cornea in a newborn signals congenital glaucoma until proven otherwise. These infants present with the classic triad of epiphora, photophobia, and blepharospasm, though the enlarged hazy cornea often provides the first objective finding. The elevated intraocular pressure stretches the infant cornea, causing both enlargement and edema that creates the characteristic cloudy appearance. Immediate ophthalmology evaluation can preserve vision through pressure-lowering surgery. Purulent eye discharge appearing within the first week of life requires immediate treatment for presumed gonococcal conjunctivitis. Unlike the more common chlamydial conjunctivitis that presents later, gonococcal infection can rapidly progress to corneal perforation. Treatment with systemic and topical antibiotics cannot wait for culture results. A white pupil, whether from cataracts, retinoblastoma, or other pathology, always represents an ophthalmologic emergency requiring immediate evaluation to determine the underlying cause and preserve any visual potential.